Today. Welcome to today's Cardiac Rehabilitation Rounds. I'm Jennifer Reed, Program Chair of Cardiac Rehabilitation at the University of Ottawa Heart Institute. Last year, we launched this Cardiac Rehabilitation Rounds series with presentations scheduled every other month, focusing on international researchers to increase knowledge translation and strengthen collaborations in cardiovascular prevention and rehabilitation, both within and outside the Ottawa Heart Institute. We are therefore very honored to welcome Dr. Kenneth Freedland for this hybrid event. We have audience members in person in the Fuston-Ellis Auditorium at the University of Ottawa Heart Institute, and also audiences joining online from across the globe. For those in the room, any questions following the presentation should be posed using the standing microphone. For those joining us virtually, submit your questions using the Q&A feature. We will also be accepting live questions at the end. Use the hand up feature. You'll be asked to unmute by the moderator. Use the chat feature if you're experiencing any technical difficulties. Well, I'm, as I mentioned, very honored to have Dr. Freedland joining us virtually this afternoon. His presentation will focus on psychiatric comorbidities and social determinants of health in heart failure. He is a professor of psychiatry and psychology at Washington University School in Medicine in St. Louis. He was the program director of the annual Summer Institute on Randomized Behavioral Clinical Trials from 2020 to 2024. His expertise in clinical trial methodology includes the selection and design of comparators for health-related behavioral trials, the role of feasibility studies and pilot trials in behavioral intervention, research, and definitions of clinical significance in behavioral trials. He chaired the NIH OBSSR expert panel on comparator group selection in behavioral and social science clinical trials and was the principal developer of the purpose-guided trial design framework. He has also served on the Multi-Center Clinical Trials Review Committee for the National Heart, Lung, and Blood Institute. His behavioral medicine research focused primarily on the role and research and treatment of depression, stress, anxiety, and self-care in patients with heart disease, especially in those with heart failure. Dr. Freedland was an associate editor of Psychomatic Medicine for over 10 years, chaired the Publications and Communications Council of the Society of Behavioral Medicine, is the associate editor for behavioral medicine for the series on advances in psychotherapy, evidence-based practice, and recently ended his term as the editor-in-chief of Health Psychology. His other numerous accolades, memberships, and role could keep us here for the duration of our rounds today. And so without further ado, please join me in a round, warm welcome applause to welcome Dr. Freedland.
Thank you, Dr. Reed. I really appreciate the invitation and the warm welcome. And I'm grateful to have an opportunity to speak to your group. As you mentioned, I'm going to be talking about psychiatric comorbidities and social determinants of health in heart failure. I have research support from the National Institutes of Health, but nothing else to disclose. So today what I'm going to talk about is I'd like to start with a brief overview of what is cardiovascular behavioral medicine, because it's a field that may be unfamiliar to some of you, at least. And then I'd like to talk about several aspects of heart failure, including social determinants of health, psychiatric comorbidities, and something about the clinical practice guidelines in heart failure and how they handle these issues. And then I'm going to close with a question for all of you that I'm looking forward to hearing some answers to. So behavioral medicine is an interdisciplinary field of research and practice that is at the intersection of medical and the behavioral and social sciences. And it draws an interdisciplinary group of researchers and practitioners, including health psychologists, physicians, nurses, exercise scientists, nutritionists, and others. And we focus on the behavioral and psychosocial aspects of physical health and medical illness. The work in this field spans basic epidemiological and clinical research. We also focus on the applied side on prevention, intervention, and clinical trials. And there are a variety of subspecialty areas in behavioral medicine, and they tend to center around medical conditions. For example, there's a very robust area of psychosocial oncology that focuses on the problems that patients with cancer have or cancer survivors. There's a whole area of behavioral sleep medicine. And of course, there is a subspecialty area in cardiovascular behavioral medicine. And I would add that many of us involved in this field sort of subspecialize. I spend more time, for example, thinking about and working on heart failure than I do on, let's say, atrial fibrillation or coronary artery disease. And I want to point out that behavioral medicine is not the same thing as behavioral health, because health is essentially a euphemism for psychiatric treatment or mental health care services. And the patients who are seen in behavioral health services may or may not have medical comorbidities, but they almost always have significant psychiatric problems. In contrast, behavioral medicine focuses on behavioral and psychosocial risk factors for incident medical conditions as well as behavioral and psychosocial problems in patients who are medically ill. We focus on common psychiatric comorbidities such as major depression. And unlike behavioral health, we tend to pay less attention to severe psychiatric comorbidities such as schizophrenia or bipolar disorder. Uh, a lot of the research in behavioral medicine focuses on biopsychosocial mechanisms that underlie relationships between behavioral or psychosocial problems and physical health or medical illness. And we also spend a lot of time thinking about prevention and intervention. So in cardiovascular behavioral medicine, various people are interested in a wide range of different topics. On the behavioral front, for example, there are people working on non-adherence to guideline-directed medical therapies. Other people may be working on sedentary behavior or physical activity in different kinds of cardiovascular conditions. There are psychological phenomena that people study or work on, such as mental stress, and particularly in relation to mental stress-induced myocardial ischemia. It's a very active area of research, or problems in coping with medical illness. Uh, some of us focus more on psychiatric comorbidities such as depression, anxiety, post-traumatic stress disorder, substance use disorders, or insomnia. And then there are folks who are focusing on social determinants of health, such as early childhood adversity, exposure to violence, discrimination, or poverty. And of course, many of us cross these different areas and work on more than one of them. Turning first to social determinants of health, the Centers for Disease Control and Prevention in the United States define social determinants of health as the non-medical factors that influence health outcomes. So these are conditions in which people are born, grow up in, work in, live in, and age in. And they refer to the wider set of forces and systems that shape the conditions of daily life, including such big forces as economic development agendas for entire countries or regions, social policies, political systems, climate change, racism, and so forth. So one way to think about social determinants of health are these are the big things in the social, physical, and political environment and the economic environment that affect health on a large scale. But we in behavioral medicine tend to focus more closely on factors that operate at the level of individual patients, caregivers, families, neighborhoods, and so forth. For example, we might be interested in what happens to people in terms of their health or their access to healthcare when they live in a low-income neighborhood or when they're exposed personally to violence. So this is less about the large large-scale forces and more about how it affects people personally or in units such as families. There's a small but I would say rapidly growing research literature on social determinants of health and heart failure. I'm not showing here the literature on other areas of cardiovascular medicine, but there's a lot of research going on in other areas as well, such as coronary heart disease. So let me just point to a couple of recent findings in the SDOH literature on heart failure. One of the more important recent studies is the REGARDS study, the Reasons for Geographic and Racial Difference in Stroke study. It wasn't just limited to stroke. They were also looking at other cardiovascular conditions. And one of the analyses that recently came out of this project was a look at cardiologist involvement in patients who are hospitalized for heart failure, because we know that the involvement of a cardiologist is associated with lower rates of in-hospital mortality and hospital readmissions, as opposed to people that are cared for only by a hospitalist or other providers. So this is a cohort with 1,000 patients and adjudicated hospitalizations for heart failure that occurred between 2009 and 2017 across more than 500 hospitals all over the United States. The patients on average were 78 years old. Half of them were women, about 40% were Black. A little more than half were low income. And they looked at a variety of social determinants of health. And they found in this analysis that patients with low income were 11% less likely to have a cardiologist involved in their care during a hospitalization for heart failure, which is really remarkable. You get hospitalized for heart failure, and yet there is no cardiologist there working with you. None of the other social determinants of health predicted cardiologist involvement, but low income did. Another finding from the REGARD study that came out just recently looked at 30-day readmissions among adults hospitalized for heart failure. This had a slightly smaller sample because of the availability of data and inclusion criteria. And what they found, looking again at a variety of social determinants of health, is that people who lived in a health professional shortage area were more likely to get readmitted than patients who lived in an area that had adequate numbers of healthcare professionals. But that was in the unadjusted analysis. In the multivariable adjusted analysis, none of the social determinants of health predicted 30-day readmissions. I would say in their defense that predicting 30-day readmissions is a difficult thing to do because event rates tend to not be super large, given that you only have 30 days to capture a readmission. And so many of the studies that do find effects on 30-day readmissions tend to be quite a bit larger than this one. But as you can see from these kinds of studies, most of the studies on SDOH and heart failure so far, at least, have been looking for these kind of large population level or health system level relationships with health service utilization or maybe with mortality. And one of the problems in this literature is these studies tend to rely on easily available but crude electronic medical record data on social determinants of health. There are ICD codes for SDOHs. There are certain kinds of face page data, but they tend to be used as proxies for genuine social determinants of health. If you can capture something easily from the record, like race, that is maybe only the tip of the iceberg of what's going on with patients in terms of social determinants. Now, at my center, we are in the middle of a study on social determinants of health in heart failure. but it's from a cardiovascular behavioral medicine perspective. We expect to complete the study later this year, but unfortunately, I don't have any findings to release to you yet. But what we are doing in this study is we are interviewing in depth recently hospitalized patients with heart failure to ascertain a wide variety of self-reported social determinant of health exposures, both recent and remote, including such factors as domestic violence, loss of family members to violence, which we're finding to be surprisingly common, disturbingly common, financial strain, occupational stress, lack of transportation, which of course affects people's ability to access medical care, and a wide variety of other factors. And we are looking at the relationships between these social determinants and psychiatric comorbidities, the severity of illness, a variety of medical comorbidities. We're also looking at how they may affect multiple hospital readmission rates and also mortality. Turning now to psychiatric disorders as risk factors or as comorbidities in established heart failure. There is a much larger and much longer history of literature on psychiatric factors in heart failure than there are on social determinants of health. The earliest paper that I found on the subject goes all the way back to 1945. And there was a little blip of interest in the mid 1970s, but really a tremendous amount of interest in psychiatric comorbidities in heart failure and also psychiatric factors as risk factors for incident heart failure, basically in the 2000s and especially since around 2015 or so. Now, large epidemiological studies have documented a wide variety of prevalent psychiatric disorders in the general population. Lots of people out there in the general population have one or more psychiatric problems. In fact, it's more common to have two or more psychiatric problems than to have just one. But little is known about the prevalence or effect of most psychiatric disorders in patients with heart failure, with certain exceptions. There's been a fair amount of work on depression, a growing amount of work on anxiety. There's been some interesting research on substance use disorders, but many of the other psychiatric problems that people with or at risk for heart failure just haven't been studied very much. Problems such as bipolar disorder or schizophrenia. Now, our ongoing study, the one where we're looking at social determinants of health, is also the first that I'm aware of to use a structured DSM-5 interview to diagnose a wide range of psychiatric comorbidities in patients with heart failure. So we're going to have data, interview-based data, both on social determinants and on a diverse range of psychiatric comorbidities, rather than focusing on just the usual suspects. Let's start with just a little bit about alcohol and substance use disorders. I've gotten more and more interested in this subject in recent years because alcohol, cocaine, and methamphetamine in particular contribute to the development of many cases of cardiomyopathy and heart failure. And unfortunately, these are addictive, and so their use often continues after the patient has developed heart failure. It's really stunning when you read some of the records of people who are very severely ill with heart failure and with other medical problems, and yet they're still drinking heavily, they're still abusing cocaine or whatever. It just, you might hope that developing a very severe, life-threatening medical illness would be kind of a wake-up call, but it doesn't necessarily work that way. One of the most recent studies on substance use in heart failure looked at over 11,000 patients with heart failure, um, including over 15,000 hospital encounters for heart failure at University of California at San Diego between 2005 and 2016. They found that 15% of all of the patients had a substance use disorder diagnosis in the electronic medical record. Of course, some of these problems are underdiagnosed because many times they aren't even asked about. And when they are asked about, patients are not always very honest about what they're going through. But anyway, this seems like a reasonable estimate to me, if maybe on the low side. Um, you can see that there's a pretty substantial difference in age between patients who were diagnosed with a substance use disorder versus those who weren't. The ones with substance use come in more than 10 years younger on average than the ones who don't have a substance use disorder. And it also turns out that all-cause mortality is a little lower in the patients who are using alcohol, cocaine, meth, or one of the other substances. Again, let me repeat that. All-cause mortality is a little bit lower. This is not a big significant difference, but it's a trend in that direction, and it echoes what's been found in previous studies. But I just have to say that this slightly lower mortality rate, in my opinion, is an artifact. The real problem is that substance use contributes to an earlier age of onset of heart disease and particularly heart failure. So in the long run, I think people who are abusing alcohol or drugs are probably going to have shorter survival rather than better survival. But we don't have good longitudinal data on this question yet. I think it's an important area to investigate further. When they broke down their data according to the type of substance use, they found that opioid use was the most common, reflecting current day trends. Meth use was not far behind. Lots of people were drinking, and the others were much less prevalent, although marijuana use was gaining traction. But if you look at the trends over on the right-hand side, um, the the opioid crisis seems to have been improving a little bit, and that's reflected in the heart failure population. That fewer people are coming in with opioids on board, but what we're seeing is a problematic upward trend in people getting admitted with heart failure who have methamphetamine on board. There's also quite a lot of alcohol use. It's hard to say whether there's much of a trend, but it's at minimum, it's not really going down. Um, Fortunately, cocaine seems to not be getting much worse, and marijuana seems to be tapering off a little bit. And fortunately, PCP isn't that big of a problem in this population. So one of the most concerning trends, again, is about the increasing use of methamphetamine. When they looked at what substance use diagnoses as well as medical comorbidities did to the risk of hospital encounters. Now, this incorporates the fact that many patients are readmitted more than once. So this takes that into account. And the bars that are in red are substance use diagnoses, and the ones in blue are other medical conditions. So we see the biggest risk factor for readmission is methamphetamine abuse. Um, you're at a lot higher risk of getting readmitted if you're a meth user, uh, followed by atrial fib, a variety of other comorbidities, Here we have opioid and cocaine abuse being fairly significant risk factors, opioid being more concerning because it's more prevalent than cocaine. Now, alcohol uh, use is more prevalent and also, uh, a pretty big factor in readmission risk. And I have to say, there's been over the years controversy about whether alcohol may have some cardiovascular benefits, but the most recent evidence is pointing to the fact that alcohol simply isn't good for your physical health, really in any way, even in moderate or low levels of alcohol use. Let's turn then to depression and anxiety in patients with heart failure. And this is what I've been working on more than anything else. Both of these are common problems in patients with heart failure. They're highly comorbid with one another. People who are depressed are often anxious as well. Relatively severe forms of these problems are psychiatric disorders. They're psychiatric comorbidities, including major depression and generalized anxiety disorder. And there are also milder or subthreshold forms of depression and anxiety that show up a lot in patients with heart failure. The psychiatric diagnostic criteria for a major depressive episode require the patient to have at least 5 symptoms for at least 2 weeks. They have to affect functioning or be highly distressing. At least one of these symptoms has to either be depressed mood or markedly diminished interest or pleasure in almost all activities, otherwise known as anhedonia. Other potential symptoms include significant weight changes, sleep disturbances, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive or inappropriate guilt, inability to concentrate or indecisiveness, and recurrent suicidal ideation or suicidal behavior. Recurrent thoughts of death are a little less specific in medically ill or terminally ill patients because people naturally think about death. It's not necessarily symptomatic of depression, just like fatigue may or may not be symptomatic of depression in a medically ill patient. Now, one of the largest recent studies of this was taken from the US National Inpatient Sample, which looks at CMS data. And in overall, looking at over 9 million hospitalizations with a primary diagnosis of heart failure between 2008 and 2017, almost 8% of patients had a major depression diagnosis. Almost 6% had an anxiety diagnosis. But you can see from the trend lines that these problems are going up and up, both in women and men, but anxiety in particular is getting more and more common in women with heart failure. It's now at the same level as major depression in women with heart failure, so very, very common. There are significant differences between the rates in men and women, but very common in both men and women, and there's a lot of it around. So this is in contrast to what's going on in the general population, where prevalence rates of both anxiety and depression have been relatively stable over these years. What about depression as a risk factor for incident heart failure? One of the sources of data on this is the Southern Community Cohort Study of over or almost 24,000 participants, middle-aged, 70% Black, 64% women, mostly low income. They found, using the Center for Epidemiological Studies depression scale, a relationship between a more severe depression and a higher 5-year probability of developing heart failure. But what is especially interesting about this study is they looked at whether antidepressant use moderates this relationship. And in this study, it clearly does. If you're taking an antidepressant, there doesn't seem to be much of a relationship between depression severity and the incidence of heart failure. Whereas if you're not taking an antidepressant, the risk of developing heart failure goes up as a function of the severity of depression. There have been at least 7 other large cohort studies that have looked at this question. Several found trends, but not significant associations. 4 did find significant associations with a variety of different hazard ratios. A recent meta-analysis found a significant but relatively modest risk, but a somewhat earlier meta-analysis that was limited to prospective cohort studies found a pretty robust relationship with a hazard ratio for depression of 1.23 in relation to incident heart failure. We at our center conducted one of the earliest studies of depression in hospitalized patients with heart failure. And 20% of these patients met the DSM-4 criteria for major depression based on an in-depth interview. 16% met the criteria for minor depression. And a full 51% scored above the cutoff on the Beck Depression Inventory. And this is one of the points I'd like to get across, that when you look at depression questionnaires and simply use a cutoff, you're capturing a wide range of depression severity from very, very mild to more severe. Whereas when you're looking at diagnoses of major depression, far fewer people tend to meet those criteria. Best estimates are around 15 to 20% point prevalence of major depression in patients with heart failure. But what we found is that the prevalence of major depression depended quite heavily on both New York Heart Class and on age. And you can see the worse the heart failure, the higher the prevalence. But that is especially the case in younger patients. If you are relatively young and you have severe heart failure, that is a recipe for having major depression. We found more recently that depression is associated with worse heart failure self-care. We had a cohort of 400 patients hospitalized with heart failure, and we used the PHQ-9 depression scale, which is very widely used these days. And we also administered the self-care of heart failure index, probably the most widely used measure of self-care in heart failure. And we found that there is a pretty strong association between depression and poor self-care maintenance, which are the things that heart failure patients need to do day to day to maintain their health, and also a strong relationship with poor self-care confidence. There's not a clear relationship with self-care management, which is what you do when you notice new or worsening symptoms that may be indicative of the development of acute heart failure or an exacerbation. It doesn't seem to be related to that, but it does seem related to other aspects of self-care. We also found in this cohort that depression predicts multiple hospital readmissions. We followed these patients up for 2 years. Almost 30% of them died during this period. The PHQ-9 depression score predicted a higher rate of multiple all-cause readmissions over 2 years. And this was especially true in severely depressed patients. As you can see from this graph, the blue line are people that are in the non-depressed range, and the black line are people that are in the mildly depressed range. This red line represents hospitalizations among people who have more severe depression. Each little triangle on this line represents a unique admission. So the same patient can show up more than once on this line. But you can see that starting at around 5 months after the index hospitalization, people with severe depression rack up more and more rehospitalizations, and that includes some real frequent flyers who get readmitted over and over and over again. Depression also predicts all-cause mortality in heart failure. Here's one of the meta-analyses that's been done on that. In univariate analyses, there's a pretty robust effect, hazard ratio on average of about 1.75. This goes down in multivariate analyses, but it's still highly significant. We did the longest study of survival in patients with heart failure. Going back to that early cohort that we amassed, we did a 20-year follow-up of survival, maybe one of the longest follow-ups ever done on heart failure patients. And I know this graph may be a little hard to see, but the people on the top line are the ones who were non-depressed back at baseline, and the ones in the bottom line had major depression. So you can see that even out over 20 years, the effects of major depression during an index hospitalization persist and continue to affect survival, such that people with major depression have shorter survival times. Well, so we know depression's bad for you if you have heart failure. It's bad for you if you don't have heart failure. But is it treatable? I would say yes, although the major antidepressant treatment trials have generally been pretty discouraging. One of the most important being the SAD Heart CHF trial of 469 patients with major depression and heart failure who were randomized to sertraline or placebo. There was really absolutely no difference between the groups. But as you can see, everybody did get better over time, on average at least. And another big one was the Mood HF trial, was done over in Europe with 372 patients. They were randomly assigned to 24 months of escitalopram or placebo. Absolutely no difference in depression or in the risk of all-cause death or hospitalization. So discouraging news for common antidepressants. We, however, did a trial of cognitive behavior therapy for major depression and heart failure. CBT is one of the best tested non-pharmacological interventions for depression in patients in general. And so we wanted to see whether it's also effective in the context of heart failure. The primary outcome point was at 6 months. Primary outcome measure was the Beck Depression Inventory. And as you can see, the patients with who received CBT had substantially lower BDI scores at 6 months, and this benefit continued on out to 12 months. They also, even though we weren't specifically treating anxiety, they had lower anxiety scores at 6 and 12 months, and they had higher quality of life scores on the Kansas City Cardiomyopathy Questionnaire. We subsequently tried a somewhat different approach. We wanted to see whether not only could we improve depression, but would treating depression also help people improve their self-care? And what we did in this more recent study was we randomly assigned depressed patients to CBT or to usual care. And then starting 8 weeks into their involvement, everybody received an intensive heart failure self-care intervention from an experienced cardiac nurse. We wanted to see whether being in the CBT arm would help people benefit more from self-care. We also wanted to see whether, regardless of what arm you were in, if having lower depression scores made it easier for you to improve your self-care. And we found really no difference in self-care. It didn't matter how undepressed you got. It didn't matter whether you were in the CBT arm or not. We got very nice results on depression. But what we did find is what matters in improving self-care is whether you have deficient self-care to begin with. If you already have fairly good self-care, no amount of intervention seems to make any difference. So the lesson from this is don't wait to get people undepressed to start working on their heart failure self-care. And also don't waste your time on people who already have good self-care. Work on the people who are having problems with that. Here's a even more recent study, larger study, looking at the comparative effectiveness of behavioral activation, which is a component of CBT that can be effective in its own right for depression, compared to evidence-based collaborative antidepressant management. And we see from this study that people in both groups improved over time, and that there were really no differences at 3 months, and that the benefits maintained up to 12 months in both arms. So the lesson from this is, despite the discouraging antidepressant trials, that people can benefit either from a psychotherapeutic kind of intervention or from medications, and that can help them to get better and hopefully to stay better. So to summarize then about depression, depression is a risk factor for incident heart failure. It's prevalent in patients with heart failure, and it predicts worse heart failure self-care, worse heart failure related quality of life, uh, a higher rate of multiple rehospitalizations, worse survival. It's treatable with antidepressants and with cognitive behavior therapy and behavioral activation, possibly also with other kinds of interventions. Notably, exercise can also reduce depression in patients with heart failure, but there is a catch that depression decreases motivation to exercise. It's hard enough to get anybody to go to cardiac rehab or to get engaged in exercise, much less if they're depressed. So there's a kind of a catch-22 about using exercise to help people overcome depression. But if you can get them to exercise, it has a variety of benefits, obviously, including helping them reduce depression. But depression is under-recognized and under-treated. So I want to close with looking at the heart failure clinical practice guidelines. What do they say about depression as a comorbidity? Starting with the Canadian heart failure guidelines, they say absolutely nothing on the subject. In fact, they say nothing about other psychosocial or behavioral problems in patients with heart failure. What about the American Heart Association, American College of Cardiology, Heart Failure Society of America guidelines? They say as close to nothing as you can get about depression and most of these other problems. But what about the European Society of Cardiology guidelines? A couple of brief paragraphs in there about depression, but nothing very specific. No solid guidelines on what to do. So I have to ask you why, you folks who work with patients with heart failure and other cardiovascular problems, given all of the research on depression and heart failure, given all of the adverse effects of depression, and given the treatability of this problem, why don't cardiologists and other people involved in the care of people with heart failure, why don't they seem to care about it? Now, I'm not asking that as a criticism or to be cute. I really am interested in the answer because we need to find out to inform future research in this area to see whether and how we might be able to change future clinical practice guidelines and future clinical practices in cardiovascular care, because the status quo is not particularly satisfying. I think there may be a variety of possible reasons under the heading of futility. Maybe people think, well, depression is a low priority relative to other clinical problems in patients with heart failure. Maybe people think, well, this is just a natural, inevitable response to illness. It's probably unavoidable. Don't bother with it because people are going to have it no matter what. Maybe you think, hey, depression is somebody else's problem. I'm too busy dealing with it. As a matter of fact, I've heard from cardiologists who say, look, I don't even have time to deal with smoking. There's lots of times, lots of things I don't have time to deal with. Depression's one of them. Somebody else has got to deal with it because I can't. Um, maybe the problem is more one of skepticism. Maybe you'd pay more attention to depression if the research findings were more convincing. Maybe you don't think the research is good enough on this, or maybe you don't think the effects are strong enough. Maybe you don't think the interventions are good enough or practical enough. Maybe you'd pay more attention to it if the guidelines actually talked about it and gave some useful guidance. Or maybe you're more open than that. Maybe you weren't very aware of the problems related to depression, but maybe now that you're learning more about it, you'll take it more seriously. Or maybe you already care about it and you'd like to do more about it, but there's not much you can do on your own. And maybe treatment services are hard to find. There's a real shortage of mental health um, resources and behavioral medicine resources. But maybe if those problems could be fixed somehow, you'd certainly be open to dealing with it. And if you do think it's an important problem, what kinds of solutions might you prefer? Do you think maybe more continuing medical education on recognition and treatment of depression in cardiac patients? Maybe some help with screening? Maybe more referral resources, more access to CL psychiatry or psychotherapy services? How about maybe a collaborative care program to help with depression and antidepressant management? Or how about maybe an integrated cardiovascular behavioral medicine service? And I would note here that integrated behavioral services are a lot more common in some areas of medicine. For example, every major cancer center has a psychosocial oncology service, but major centers of cardiovascular care tend to not have cardiovascular behavioral medicine services. They're rare in cardiology. So I'm going to leave it at that. And again, I'm very interested in how you think about these things because um, we've been doing a lot of work in this area. We think it matters, but obviously that's not an attitude that's universally shared. So I'm open to any and all possibilities. So thank you for your attention, and I'd love to entertain some questions. Jennifer, you're on mute. Yeah,
Step one, unmute. Thank
great.
you. Thank you for such an interesting and informative presentation. I particularly enjoyed how you've ended with some questions for the audience. As you know, we're a very multidisciplinary team here at the University of Ottawa Heart Institute within our cardiac prevention rehabilitation teams. They're well represented today, so I'm hoping they may have a few responses to your questions. Before we do get to the Q&A, I just want to share and perhaps remind everyone that Dr. Freedland has graciously agreed to join us for a round table tomorrow, a more personal opportunity to have discussions, ask further questions, share research. So if you haven't seen the particular link, it's been shared on our internal communications and on all of our social media posts. These are open to everyone, healthcare providers, researchers, and trainees. So if you'd like the opportunity to spend a few more minutes with Dr. Freedland, it's tomorrow at 2 p.m. Eastern Standard Time. I recognize we have individuals joining across the globe, so perhaps just do a bit of math on what that particular time will be for you. So we will shift now back to the Q&A. I'm going to start it off with Dr. Liu, who's our Chief Scientific Officer, who is a specialist in heart failure. So perhaps he has some thoughts, and then I will moderate following his questions and discussions, the Q&A and the chat. So please keep the questions coming.
Great, thanks, Jennifer. Is the mic up? Yeah, great. Okay, super. Yeah, so thanks so much, Kenneth. That's actually fantastic. And of course, following your work and in terms of the CBT in depression is really a landmark study. So we are actually very interested in this area because we have a National Heart Failure Alliance, and the patients, when we actually did the survey, tell us, so the number one concern they have are not actually anything related to their heart, whether it's ejection fraction or mortality. But number one is actually mental health, and that's the depression and anxiety. So this is actually, a major incentive. And the two is actually related to brain as well, it's a cognitive impairment. And in fact, it's actually listening to our patients, but also working together with many colleagues. We have actually obtained a major federal grant. It's called Major it's called a Canada Research Excellence Fund, and Brain Heart Interconnectome is the project. So it's $109 million, to actually address this problem. And in fact, this is actually one of the major area of focus for us, the interface between like a heart failure, and all the mental health challenges. And and then we actually putting a review paper, together with many colleagues around the world, in major medical journals to actually address this. So a couple of things that in terms of answering your question and, potential areas of collaboration and the interesting aspect also on the social determinants as well. So yeah, so I think there are, and in fact, in our paper, we actually reviewed the history of brain and heart interaction, and so in fact, it's about a century ago in which there's a divergence of sort of different organs in the body, and whether that's on the medical school side, on the specialty training side, on the health infrastructure side, we have managed to really segment the patient into organ parts, right? Look at how our medical school is organized, our specialty, and even reimbursement. And so that actually led to all these segregation, siloing. And whereas the patient tell us that I'm the same patient, I sort of face these challenges. Why are you only treating one part of me and not the other? And why is that I need to wait 6 months, to get the specialty, service of the other when you should actually talk together. Yeah, so I think the need is there. And but a lot of it has to do with, so the way, different specialties have been, sort of taught. But I think time has come for things to actually come back together, right? It's just so much, your data is really actually underscore that aspect very much. So indeed, we are thinking of integrated services, more multidisciplinary, in fact, tools, to actually do this. So it'd be, great to collaborate on that. Certainly it'll be a lot of fun. And at the same time, we're actually delivering new national guidelines. These are the sea change guidelines, which will include not only the cardiovascular care, but also the cognitive care component, as well as mental health care component. And this is aimed at the internal medicine, primary care, and it's going to be integrated into electronic medical record system. In Canada, we are able to actually do this, more efficiently. So the two questions I have, one is that, in terms of CBT, which you really actually have really nice data on, is it something that could actually be done by, sort of a component by a multidisciplinary care team, because of the challenge for us is really, sort of access, our, psychiatry, sort of a specialist and, to do this because there are so many heart failure patients, so are there ways in which you could actually deliver CBT in a more general fashion? And then the other question actually is on the social determinants of health, because many of those factors, in fact, actually cluster together, right? So whether it's a low income, whether that's in terms of access to care and many of those things. And this is a little bit kind of unrelated, but do you have ways in which you think, this is a major challenge we have in health system, that's major inequities, right? In terms of the access, in terms of the delivery, in terms of outcomes. And, are there programs in your area, or when you think about it, that actually will be able to effectively address this inequity? Of course, this is a huge, challenge that we all face. And, sort of, so two questions for you. So, but anyways, enjoyed your presentation tremendously.
Oh, thank you very much for those questions. Those are very exciting developments. I'm really happy to hear about that. And I want to make a pitch. Up in Canada, there is this group called the International Behavioral Trials Network, headquartered in Montreal. And if you haven't connected with them, I hope that you will consider that, because there's a lot of behavioral talent involved in that group.
Yeah, so we work together. Yeah, so.
Oh, good, good, good.
Yeah.
And just to react to something that you said, we find oftentimes in looking at psychiatric problems and social determinants of health, that for many patients, heart failure is the least of their problems. Just imagine having severe multi-morbidity and on top of that, having to deal with problems like my son is in prison, or my neighbor just got shot, or my husband died and we don't have enough money to get by from month to month. These are really daunting problems, and I think going first to your second question, um, they are mystifying. I'm aware of hospitals that have set up programs to try to deal with social determinants more directly with social work and case management and so forth. But really, there's a limited amount that a hospital or health system can do about a problem like homelessness or violence in the community or domestic violence. So I think there's some fledgling efforts that are being made, but it's a really tall order to take on some of that. And I agree that these social determinants tend to cluster. People tend to not have just one problem, they tend to have multiple problems. Going back to the CBT, I would like to make a pitch for as you're looking around for ways to deal with this, maybe think in terms of a stepped care approach to the problem. There are ways to use behavioral activation as maybe a first step kind of intervention for people who aren't too severely depressed. It doesn't necessarily have to be a doctoral level provider. I'm involved in a study right now with surgical patients where the providers of behavioral activation are folks with bachelor's or master's degrees. They're doing, a perfectly fine job of behavioral activation. But I think you can expect, at best, maybe about a third of patients will respond to that, at least with full remission of depression. And so there need to be some second and maybe third steps for people with more severe or more intractable problems. But if you set it up as a stepped kind of process, you don't necessarily have to bring out the big guns. Our CBT trials offer up to 6 months of cognitive behavior therapy for people. It's just not practical in a lot of settings. Fortunately, most patients don't need the whole 6 months, at least not very intensively. But if there's a less intensive, less expensive way of helping at least some people, maybe start with that and then move on to something more intensive. And also, no need to wait around for starting antidepressants. If somebody is depressed, that's something easier to get moving on.
Yeah, thank you so much. That's so practical, and look forward to following up with you. Yeah, thank you.
Great.
Thanks, Peter. We have another question here. Does it matter whether depression precedes or follows heart failure in terms of treatment and outcome?
Interesting question. That's been studied a lot in relation to myocardial infarction, much less in relation to heart failure. I will say, though, that the typical age of onset of depression is in the teens and 20s. Many people that you find later in life that are depressed are not getting depressed for the first time. In fact, some people who are getting depressed for the first time, that may be connected with the early onset of dementia. So look, and you will very often find people have had problems earlier in life, and it's happening again later in life. Depression tends to be a recurrent or chronic problem in many, many cases. And as far as I know, it doesn't really matter. The more depression you've had, the worse. But it doesn't really matter if you wait to get depressed until after you've developed heart failure. I think that's probably the exception rather than the rule.
Wonderful, thank you. And we'll squeeze in one last question here with our remaining few seconds. As research on social determinants of health in a heart failure context is emerging, could you provide any lessons learned from the longer line of research on psychological aspects in heart failure that may help to inform research on SDOH?
Yeah, I think one of the key lessons is that all of the different kinds of things we study, there's often more than one way to measure it. And the findings that you get depend a lot on how things are measured. Like I said, a lot of the initial research on SDOH and heart failure uses conveniently accessible variables out of the electronic health record that I think in many cases don't really capture the problems that people are facing. They're kind of crude indices. And it's the same for problems like depression. Some of the data that I showed you from other studies were based on the SES-D depression scale. That's, in my opinion, a kind of a crude measure of depression. Some of our studies, in contrast, have used more clinical questionnaires or even in-depth psychiatric interviews to get closer to diagnoses of psychiatric conditions rather than quick questionnaire scores. So it matters a great deal how you measure things, how carefully you measure, how long you follow people up. So I think that's an important lesson learned moving forward in the SDOH research.
Well, I want to thank you for your time and pass along some few final comments here. There are notes of thanks, and you've provided an excellent and interesting presentation. So again, I want to reiterate on behalf of the entire University of Ottawa Heart Institute and specifically our prevention and rehabilitation programs, what a very interesting and insightful presentation this morning. I'm sure there will be many discussions in the hallways regarding the questions that you posed at the end of your presentation. And I hope others will join me tomorrow in our roundtable discussion with you, because I think it's a fabulous opportunity for our providers, our scientists, and our trainees to ask a few more questions in a roundtable personal manner. So we will look forward to tomorrow. Thank you again.